Alrighty, let's get started. Good afternoon, and thank you for joining us for the second session of our traumatic brain injury webinar series. Today's presentation is TBI treatment across the range of severity. I'll start quickly with some logistics, and then we'll get into it. If you could just switch the slide. Thank you. Okay. So in order to earn your CEs for this session, you must attend the entire session in full, so the 1 hour, and you have to complete the 3 poll questions that will appear throughout the session. And if there's any questions about the CEs, you can reach out to me at paige.krogan@carispartners.com, and I will guide you through that process. Then also, if you have any questions about the content throughout the presentation, if you could please enter those into the chat or the questions box. We'll get into them at the end in our Q&A session. And now I'll pass it over to Dr. Spalding-Dias to take us through.
Thanks for the introduction, Paige. I'll just say a quick intro about myself. So I'm a physiatrist or physical medicine and rehabilitation specialist, and I am also board certified in brain injury medicine, which is a subspecialty of physical medicine and rehabilitation. And I worked in a variety of settings. I worked as an outpatient primary treating physician in an occupational medicine clinic in Kaiser in Northern California. And I've worked in the UC Davis Medical Center as an attending for the hospital-based services, so the consult service, seeing patients with these types of injuries alongside the neurosurgeons and trauma surgeons in the ICU, also running the acute rehab program there, working to get those patients out of the hospital and on to the next level of care that's most appropriate for them. And that's really what today's talk is mostly about, is understanding and navigating the levels of care for patients with traumatic brain injury. Currently, my clinical practice is at a neurorestorative, 2 facilities in the greater Sacramento area, and I've been working with Carisk partners as a clinical specialist for about 9 months now. So in talking about TBI treatment today, we're going to just sort of briefly talk about severity of injury, and then I'm going to kind of break down the levels of care, sort of what it looks like going through the healthcare system with a moderate to severe traumatic brain injury, and then also looking at what care for mild TBI looks like. And then closing with some comments on really the lifetime of care that's needed for patients who sustain these kind of injuries. So just to briefly look at here, this is a slide from my last talk, if any of you guys attended that same one. This is really just some of the factors that we use to determine the severity rating for a traumatic brain injury. So GCS being the Glasgow Coma score at the time of presentation or immediately after the injury, or if it changed within the first hours or days after treatment. So mild would be 13 to 15. 15 is the highest and a normal score. Moderate, 9 to 12, and severe would be 3 to 8. 3 is the lowest score you can get on the GCS. Then the next category just speak about alteration of consciousness, which is just that sort of dazed and confused period. They might not actually have lost consciousness, or that the LOC is loss of consciousness, where they've actually blacked out or passed out, but they could just have that alteration of consciousness where they're just not quite aware, a little bit fuzzy, a little bit cloudy at the time, and then thinking back and remembering things. It could be just a little bit cloudy. That would be the alteration. So you can see the time durations there for the different categories. And then the last column is the post-traumatic amnesia. So that's the period of time that they don't have good recall in terms of orientation, knowing where they are, what's going on, why they're there, knowing the date, those kinds of things, sort of being oriented to what's going on around them. And then the cutoffs for that, for how long the post-traumatic amnesia lasts. So that's just a really brief overview on severity. But I wanted to take a minute to really talk about the neurobehavioral sequelae of traumatic brain injury. It's kind of one of those things that once you see it, you really know it and understand it. And if you haven't seen it ever, actually talk to a patient with a brain injury or experienced it directly in some way, it can be really hard to understand and to describe what it's like for someone who's had a brain injury. But I just kind of wanted to take a minute to talk about some of the things that we see. Disorientation and confusion, so just not knowing where they are, why they're there. Maybe they don't remember their name. Maybe they don't remember their family. Maybe they remember some things, but it's not really clear. So that's really challenging for family members. If they don't remember them, that can be really disconcerting to family members who are coming to visit their loved one. Obviously, it's challenging for the patient to live in a world like that and feel that way. Other thing, depending on which parts of the brain are involved, they may have really significant changes in their personality or behavior. So they might have been a very calm and docile type of person to begin with, and after the brain injury, they can have frontal lobe involvement, and they can be very impulsive and rude, or very even aggressive or irritable. Really different personality changes that wouldn't have been there before, and that can be a real challenge for family to get to know their loved one with this new personality. And it can be really hard to care for someone when they're yelling at you all the time and throwing things at you, and just walking on eggshells so you don't set them off. That can happen. Agitation, restlessness, and irritability are all kind of some of those things that can go along with it. And a lot of times over time, over the course of recovery, these agitation and restlessness and irritability can improve, where they're not always as big problems as they may be early on. But for some people, they do stay as ongoing challenges, and it can make it really hard to engage with other people, with the community, to get out in the world and not cause a fight or a problem, or struggles with law enforcement, getting assaulted because of the way they're behaving in public inappropriately. Things like this can happen with people who've had brain injuries. And the impaired executive function, that's something we talk about all the time, but what does it really mean? It's really the inability to do things that you need to do on a daily basis, in terms of keeping yourself organized, taking care of what you need to do for the house, the bills, getting paid, managing the money, doing things in an orderly fashion, keeping your house organized and keeping things where you need them, so when you need them, you can find them. Those kinds of things. And if you have impaired executive function, all the daily aspects of life become challenging. It can be really hard to just carry out your day without assistance. And that's why these cases can be so challenging. Impulsivity is not thinking things through, just jumping right into action or responding to things that they're concerned about, that seem so important to them. And they'll just want to go to the bathroom, or they might just get up and take off in the middle of something that's going to be a problem if they just leave right away. Perseveration is also a really interesting symptom, where they just get stuck on an idea. And it could be that they're in an acute rehab setting, and they're like, I just need to go home. I'm just going home. I just need to get out of here. And that's all they can think about. They can't focus on their therapies or their work or their care, because they are so worried about the perseveration, or about the idea of getting home, the thing they're perseverating on. The other thing I wanted to add on here is confabulation. So confabulation is basically filling in the blanks in their mind. So it's not lying, but it's telling things that aren't true. So what happens is there's gaps in their memory and their awareness of what's going on, and they don't understand. Their brain doesn't understand why. And so instead of just saying, I don't know why I'm here, I don't know how I got this cast on my arm, their brain actually fills in the holes with sort of false memories or false ideas. And so they say, yeah, I got this cast on my arm. I was kicked by a horse. And if they were in a car accident in real life, but they really believe it, and they think, that must be why I have this cast on my arm. So a lot of times they can sound like they're lying and making things up, but it's not intentional. It's just their brain is automatically filling these things in. And one thing, when people early on in the hospital setting aren't really being cared for by physicians who are aware of brain injury symptoms and presentations, they often describe it as delirium or intentional bad behavior, that the person's acting out intentionally, and it's really not the case. So it's really important that people who have brain injury are being cared for in appropriate settings, where the providers know and understand how to manage all of these complex symptoms. So here, just to speak to the Careflow for moderate and severe traumatic brain injury. And by Careflow, I mean, how does the patient get from an acute hospital back to the community? I have this slide just to show you how crazy this Careflow can be. And we're going to go through each of these categories in more detail, but just to sort of show you what can happen. People start their care in the emergency department, usually for moderate and severe TBI. They're hospitalized. So they're brought into the emergency department, helicopter or ambulance. And from there, they may go to an LTAC. They may go to an acute rehab. They may go to a subacute. From the LTAC, they may go straight home. They may go to an acute rehab. They may go to subacute. From the acute rehab, they may go to subacute, or they might go to subacute first and then back to acute rehab, and hopefully eventually getting to something that looks like a home environment or a transitional living setup or a residential brain injury program. But that's sort of the ultimate goal, is to kind of restore a normal community living environment, for, if at all possible. Now we'll go through each of these categories and kind of understand how and why people go from one level of care to another. And that's really what I want to try and help you guys understand better today. So please, if you have any questions, just ask along the way, and I'll make sure I answer them at the end, because this is a lot of the work I did when I was at UC Davis, was helping figure out how do we get people out of the hospital and what's the next best level of care. And then from there, how do we get them home? So that's really the goal of today's talk. So acute hospital. Everybody on the call knows what acute hospitals are and what they do. That's your trauma centers, where they have the emergency department, ICU, med-surg levels of care. And their role is to save lives and stabilize the patient so that they can then move on to their rehab. But it's also really important to realize that not all acute care hospitals provide the same level of appropriate care for patients with moderate and severe brain injuries in particular. There's the Brain Trauma Foundation in-hospital treatment guidelines. I have the website listed here as well. So if you wanted to look at them for yourselves at some stage, but really what this is was a group of clinicians came together and really outlined very clearly, very specifically, what should be done for patients who have moderate to severe brain injuries to improve their outcomes. And they created a very extensive list of guidelines of care of what should be done. And if these guidelines are followed, the patients have reduced time spent in the ICU, reduced healthcare costs overall, decreased death and disability by 30 to 50%, and improved neurologic outcome upon discharge by 30 to 50%. So it's really important that as early as it's safe to transfer a patient, that they go to a trauma center that is really capable of providing this level of treatment and this level of understanding of brain injury care. I also wanted to talk for a minute about the Canadian study on brain injury mortality. And this is I think, really important to think about. So the study was conducted in 6 different trauma centers across the country of Canada. And the overall hospital mortality was 31.7%, but it ranged. The in-hospital mortality ranged from about 10 to 44% across the different centers. And so they wanted to see why. Why were people living more in one hospital compared to another? And most of the deaths were due to withdrawal of care. So meaning that the family in discussion with the treating team decided to withdraw care. And the rate of withdrawal of care ranged from 45 to 86% across those different trauma centers. So 86% is a really high percentage for withdrawal of care in the setting of a severe TBI. Now, the incidence of withdrawal of care varied by center. And what this means is that depending on which trauma center you went to, they were more likely to die by withdrawal of care in that trauma center, up to the odds ratio of being 0.4, meaning it's only less than half the chance of being dying by withdrawal of care, to almost 2.5 times as likely if you were at a different trauma center, depending on which area you were injured in and which trauma center you went to. And about half of deaths from withdrawal of care were in the first 3 days. And I have a whole 3-hour lecture series on prognosis and severe TBI. And we can't go into all of that today, obviously, but it's the summary point of that whole field of research and work is that you can't know in the first 3 days what someone's going to look like a month later, a year later, 5 years later. And so to make those kinds of decisions early on is it's not based on any accurate information that this person's going to have a poor quality outcome, because we really don't know. Of all the different markers we have of severity, there's none that early on within 3 days can clearly say, okay, yes, this person's going to have a bad outcome. And I use quotes around bad outcome because outcome is really subjective. You know, it really depends on the family and their perception of quality of life. And there's also a large body of literature that says, that demonstrates that care providers, first responders, paramedics, emergency room nurses, physicians, ICU doctors, trauma surgeons, neurosurgeons, don't value a life with disability. And so the people who are counseling the loved ones to choose withdrawal of care in the first 3 days may be biased against living a life of disability with a brain injury. And so we have to be really careful about how those decisions are being made and when those decisions are being made if we're really going to offer the best care for our patients. So, moving on after that, sorry, my little soapbox there. But moving on, the next level of care, so after acute hospital, the next level of care I want to talk about is a long-term acute care, or LTAC. Out here in California, these are mostly Vibra and Kentfield, will be sort of the biggest ones out here where I practice, but there's many different ones across the country. They really provide an acute hospital level of care in that they can provide daily physician visits. They can do some surgical procedures like pegs and trachs and other minor procedures. In my experience, and this may be limited to the California studies, California programs, the quality of the therapy services there is really variable, but they're really focused more on the medical management of the patients with traumatic brain injury and not as much the rehabilitation management. And I'm sure that across the country that this will vary from site to site, but it really just goes to making sure that the places that our patients are being cared for within are really high quality centers that are going to provide the best care medically and from a rehabilitation perspective. So from my perspective, LTACs are really useful for brain injury patients when they still need that intensive medical management, but not quite at the acute hospital level of care. If they're on ventilators and they still need active vent management, changing settings every day, working on weaning them off the ventilator, but it's just going to take them a little bit longer than they can do in the acute hospital setting. If they have other sort of active medical issues, you know, kidney failure or things they're needing to be managed and monitored by internists on a daily basis, then an LTAC would be the appropriate setting for them. Now, the next level of care I want to talk about is acute inpatient rehabilitation. And so I ran the acute rehab unit at UC Davis for a number of years, about 7 years. And so this work is near and dear to my heart. And but the admission criteria is very specific. And these criteria come from the CMS. They must be able to participate in 3 hours of therapy a day, or in some cases, if, for example, they have limited fatigue, it can be a total of 15 hours spread out over 7 days. But regardless, it has to be 15 hours a week of therapy that they can participate in. So they have to have endurance to be able to do that. They must have multidisciplinary therapy needs. So they have to need at least 2 out of the 3 disciplines, those 3 being physical therapy, occupational therapy, and speech therapy. But they only need 2 of them. So for those patients from a brain injury perspective who are sort of walking wounded, where they really don't have many, if any, physical therapy goals, they can still qualify for acute rehabilitation based on their cognitive goals, because OT not only does the self-care in terms of ADLs of dressing and bathing, but they address the cognitive deficits as well in terms of how that affects their daily activities. And speech therapy clearly does the cognitive skills. So even those walking wounded category of brain injuries will benefit from and meet the criteria for admission to an acute inpatient rehabilitation center. But not every acute hospital program knows that and will make those referrals. So we have to be sure that we're helping to guide them to get to the appropriate level of care. They must also have not only the functional need, but the medical need. The medical necessity to warrant physician monitoring. The rule is at least 3 days per week. Many acute rehab centers have their doctors see the patients daily, but the rule is they need to be seen by a doctor at least 3 days per week. And they need to be able to participate and benefit significantly from the therapy intervention. So there have to be goals for them to achieve during the time that they're there. Now, this is time for our first poll question. So we'll let that pop up here for us. And you guys can just, it's not meant to be tricky or challenged, but just make sure if you want the continuing education credits for this, that you get this completed.
Looks like about 60% of people have voted, so we'll just give it a couple more seconds.
Great. If anyone wants a last minute chance to get their vote in, go for it.
All right, looks like we can proceed.
Okay, great. All right, can you see my screen again?
Yep, back on the slide.
Okay, great. Thank you. Okay, so moving on here. All right, so what do they really do at an acute inpatient rehab? We know the criteria, but what do they actually do? I definitely want to just mention that we think of the centers of excellence for acute rehab across the country. So obviously Shirley Ryan, Craig, Kessler, and there's other centers of excellence, but we want to make sure that they're going to a place that's going to provide really high quality rehab and medical care at the program where they go after their acute hospitalization. And really the overall goal for acute rehab programs is to provide shorter term, more intensive therapies. And it's really brain injury specific rehabilitation compared to the LTAC where it's more general rehabilitation. The role is for rapid progress with a goal to discharge home or to a lower level of care if a home discharge option isn't available. Average length of stay across all diagnoses, so that's traumatic brain injury, stroke, hip replacements, fractures, all diagnoses across the board. Generally, it's about a 2-week stay, so not very long. But depending on the severity of a brain injury, it's common to have an acute rehab stay of up to 2 or 3 months if it's a more severe brain injury and they're making progress towards recovery during that time. They get a minimum of 15 hours of therapy a week, and those physician visits a minimum of 3 up to 7 times per week. They're generally cared for by CRRNs, which is a certified rehabilitation registered nurse, who's a nurse who has additional training in rehab management, so how to manage neurogenic bowel and bladder, how to help transfer your patient, help them mobilize in ways that's going to improve their independence throughout the whole entire day, not just during their therapy hours. The participation aspect, I think, is really important because for patients to participate, you have to think about, well, they're going to be limited. So if you have a high quad, a high cervical spinal cord injury who has no ability to move their arms or their legs, and isn't expected to gain that ability through the rehabilitation process, they can still participate by learning how to direct their own care. And that means that once they leave the acute rehab setting, they can go to any setting in the world and they can have a caregiver and they can tell that caregiver what needs to be done to care for their body, how to move them, how to roll them over, how to position things, how to take care of their bowel, how to take care of their bladder, so they can still use their mind to learn what they need to know. And in brain injury and severe brain injury, a lot of times the patient may not be able to participate, but the caregiver can. So the caregiver can be there, be learning how to care for the person, how to help them, how to care for them. And so sometimes the person participating to a greater degree is the caregiver, more so than the patient with a brain injury's ability to do so. And they need to be making progress towards goals. So the classic marker of progress at an acute rehab setting is the FIM, the Functional Independence Measure, and it's just a numeric scale that basically looks at all the different categories of function and gives the number. And they're supposed to show improvements in that week to week. Now, in the lower level patients, and we're going to talk about this in a little more detail later, patients who have more severe brain injuries, not as much cognitive functioning, the Coma recovery scale is actually a good objective measure that can show progress week to week if they're becoming more alert, more aware, more interactive. That can be a marker of progress, even if they're not making gains on the FIM scores, because they're still dependent for everything, but they're actually showing progress and improvement. So the Coma recovery scale can be used as a marker of progress in an acute rehab setting. So just one slide to say, when is acute rehab needed in TBI? Really always. I think every patient with a brain injury who should go to an acute rehab unit. The primary limitations being if they really can't tolerate 3 hours of therapy a day due to pain or other symptoms. There's just no way they can be out of bed that long. Another reason would be if they have really limited therapy goals due to weight bearing or bracing restrictions. A lot of times, when they have severe brain injuries, that's not their only injury. So they might have had fractures in 3 or 4 limbs, and they're not weight bearing. They can't even get up to a chair. They can't even be transferred to a chair because they have to push through their arms to do it. And so there's oftentimes a period that the fractures need time to heal, and there's not enough that you can really do for them in an acute rehab setting if they can't participate because of those weight bearing restrictions or bracing restrictions. For example, they're in a TLSO and a C-collar, and they can't see or reach to be able to participate with their toileting needs or those kinds of things. So there might be a period of time that they need to heal before they can really participate well in an acute rehab setting. And some people really can't participate adequately if they're still in that disordered consciousness spectrum. They might not quite be ready to really fully participate in an acute rehab program, and that might be somebody who's more appropriate to go to a subacute rehab setting first and then transition back to their acute rehab later on. So just to sort of go through the 3 disciplines of therapy a little bit here. We all kind of have a general idea, but I wanted to just highlight some of the things that physical therapy works on. Gross motor skills, which generally we think of as sort of leg and trunk movements, mobility, transfers, getting out of bed, getting up, getting into a wheelchair, getting from a wheelchair onto a commode, locomotion, how they get around. So ambulation, walking, or locomoting with a wheelchair, and helping them to be able to do that more independently. And then another thing they focus on is really just maintaining range of motion in the lower limbs or the legs. Occupational therapy works on things like fine motor skills, so hand function, activities of daily living, things like dressing, hygiene, bathing, taking care of themselves, getting ready for the day, but also instrumental activities of daily living. And a lot of times this is where the cognitive deficits come into play in terms of brain injuries and needing occupational therapy, even if they don't really have the physical deficits to go along with it. Examples of these are things like shopping and meal preparation, some of those activities that require planning and organization to be able to make sure you've got enough food in your kitchen to feed you for the week, and then how to prepare the meals and what to use. And if there's both physical aspects of that in terms of how holding the knives and chopping, and the cognitive aspects of planning and preparing, making sure you're safe and aware of the fire on the stove and the water running in the sink and the water temperature so they're not getting scalded and those kinds of things. and then also focusing on maintaining range of motion in the arms. Now, speech therapy has sort of a lot of different domains. They not only do sort of speech, but there's language. So there's language is really receptive and expressive understanding. So receptive meaning their ability to receive language or understand things that are said to them, and expressive being able to express language or communicate or talk. So they deal with patients who have aphasia or inability to understand or communicate well. Also cognitive function, so things like attention, memory, orientation, executive functioning, all of those different sort of domains of cognitive functioning, they'll address each one of those. And then also in addition to the language and cognitive functioning, speech therapists will address swallow function or dysphagia if they have motor weakness or sensory problems that are causing them to swallow poorly. Sometimes with brain injury, their motor skills are fine. They can chew, they can swallow, but they're just too impulsive. They just shove their mouth too full, and that puts them at risk of choking. And sometimes it's more behavioral management strategies rather than the physical dysphagia. So here, moving on to the next level of care, we have the sub-acute rehabilitation. And so this is something like neurorestorative, where I work. Not all of the neurorestoratives across the country have this particular level of care, but the ones out in California and where I work do. And QLI is another sort of center of excellence that provides this level of care. And sub-acute rehab, they're not seen by physicians as often. So typically, maybe it's only once a week or once a month, or anywhere in between 1 to 4 visits per month. And those may be by a physiatrist or an internist or both. Their therapy is based on tolerance and goals. So they can provide up to 12 or even 15 hours of a week, like an acute rehab setting, depending on if the patient warrants that. But if the patient can't tolerate that or isn't making progress enough, that they can get less therapy. So they might only get 8 hours or they might only get 3 hours, depending on where they are in their recovery process and what their needs are and their tolerance. There's also nursing care who is trained and knowledgeable in terms of how to manage TBI compared to sort of other non-brain injury specific types of sub-acute rehabilitation programs. It's really important to understand the cognitive deficits that go along with TBI to be able to help those patients recover. In addition, they can provide ventilator care. So these are typically for people who are more stable on a ventilator compared to an LTAC. It's going to be someone who's really getting active management. So maybe weaning off the ventilator or changing their ventilator settings every day. At a subacute setting, it's maybe someone who's stable. We know they're not going to be able to wean off the ventilator. They're going to be on the ventilator for life or for a long time, number of years. But they still need it. Subacute rehabs like neurorestorative program can provide ventilator care. Sometimes I have patients who just have nighttime ventilator needs. So they're off it during the day, they have their trach caps and they can talk, move out and about the facility and outside. But at night they need the ventilator support. And some are on it 24/7, depending on their needs. The role of subacute rehab is really a longer term, slower paced rehab as compared to an acute rehab setting. And in addition to sort of that, what I call sort of transitional rehab, working on getting them from an acute injury to a home environment, sometimes people stay with us for long-term care or life care after a work-related injury. They might be too impaired to be able to get back safely to a home setting. And so we do have some patients who are with us for long-term care. When is subacute rehab needed, just to sort of quantify it a little bit, compared to an acute rehab setting, if they really can't tolerate the 3 hours of therapy a day, maybe it's too much pain, maybe it's they're still too impaired from a level of consciousness to really be able to participate in a meaningful way. If they have too much pain or their bracing is just making it too complex to get in there, a lot of times they have a big X-fix on their leg and it's just too bulky to try and move around. And so you just sometimes are waiting for those fractures to heal or for them to become more alert and aware, and then could go back to an acute rehab setting after spending time in a subacute program. And sometimes it's the ventilator needs. Sometimes many acute rehab programs cannot provide care on a ventilator. So sometimes it's the fact of the ventilator need or trach care, depending. Or if it's somebody who's maybe completed an acute rehab program that has gotten as good as they can be from an acute rehab standpoint, but they really don't have a home destination that they can discharge to safely. They don't have caregivers. They don't have a house that can accommodate them. Then they might come to a subacute rehab setting for long-term care. Now, just to very briefly talk about this in more detail in the last webinar, but just to very briefly kind of go through these.
Interrupt you real quick.
Oh, thank you.
The second question.
Yeah, thank you. We have. I'm going to just go back here just to give you guys a little clue here. We'll go ahead and go into the second poll question. Thanks, Paige.
Just a reminder that if you do want to get credit, you need to answer the poll question. So we'll leave it up for about 30 more seconds. Okay, it looks like everyone has gotten their response in, so we can proceed.
Okay, great. Thank you. Okay, you're seeing my screen again?
Yes.
Okay, wonderful. Thank you. Okay, so here, just to very briefly talk about the disorders of consciousness again. So we have really there's two scales that we talk about for brain injury recovery or neurologic functioning after a traumatic brain injury: the Rancho Los Amigos scale and the brain tree neurologic stages of recovery. And the Rancho 1 sort of correlates with coma, which there's really no arousal, no response to stimuli, no awareness, no sleep awake. The patient looks like they're asleep all the time, but if you put EEG electrodes on them and look at their brain waves, they're not showing signs of sleep. They're really unaware. Rancho 2 is correlated with vegetative state, but a new preferred term is really a state of wakeful unconsciousness. And this means that they've had a return of sleep-wake cycle. So they have periods of the day where they look like they're asleep, and there are other times when they look like they're awake. And that's looking at them both in the room. Their eyes will be open. And if you put EEG leads on them, brainwaves will start to have characteristics that look like sleep and wake. But they really still are unconscious. They really still have no awareness of things that are going on around them. No ability to communicate, no understanding, really no awareness. And so they are still unconscious, but they look awake. And that's a really confusing state for a lot of people. But they can't follow commands. They can't communicate. They can't, squeeze your hand intentionally. They can't do anything purposeful. The next level of recovery is the Rancho 3, or the minimally conscious state. And this is where they're starting to have signs of awareness present. So they're starting to actually have some understanding that there's people in the room, of what's going on around them, that people are talking to them. They're starting to be able to interact, starting to be able to follow commands. Maybe not accurately, maybe not fully. They may have, limitations where they can't move their body well either, but they're starting to have that awareness. And it can be inconsistent throughout the day. So maybe there's only about 20, 30 minutes of time during the day where they are really alert and aware and can interact in a meaningful way. And then they're fatigued for the rest of the day. They look like they're in the vegetative state again. But the next day, there's another period of time where they're alert and awake and starting to respond, starting to interact and communicate. So that's just a reminder of what those different, when I talk about disorders of consciousness, what we're talking about is really these three levels. And I just wanted to show you a little image here of what the coma recovery scale looks like. This is like one page out of a 17-page sort of descriptive manual of how to do this exam. But I just wanted to kind of highlight, compared to the Glasgow coma scale, which we talk about, that's the scale of looking at how well someone's functioning with a coma in terms of their eye movements, their communication, and their body movements. And this is a lot more detailed than that. You can see there's auditory function, visual function, motor function, oral motor, or the ability to move their mouth or be verbal, communication, and arousal. And you can see there's a different points that would be assigned. So it just is a much more detailed way of describing how someone looks in that sort of coma, wakeful unconsciousness, minimally conscious state spectrum. So you can kind of see, and if you're monitoring in an acute rehab setting or a subacute rehab setting, you'll be monitoring their progress on this, where lower numbers show decreased function. And if they're making consistently higher numbers week to week, that can be a marker of progress of recovery, even if they're still completely dependent on the FIM scores and they're not making any FIM number changes. They can be making changes according to this scale. So this, I don't even like to put this on a brain injury talk because in my mind, brain injury patients should never go to a SNF, but we have to talk about it as a level of care. And I really say patients with brain injury shouldn't go to a SNF because they really don't understand how to manage those neurobehavioral sequelae, the cognitive deficits, the confusion, the behaviors, the agitation, the perseveration. It really takes a lot of special skills to know how to manage those. And so only ever, if it's the absolute last resort, the only place this patient can go for whatever reason, would I ever recommend that a patient with a brain injury go to a skilled nursing facility. But it does happen. Now, to speak to them in a little more detail, with less opinion, they can get 3 to 5 hours per week of therapy, but often it's not neurospecific. I mean, they often deal with sort of elderly who've had strokes. And so they can have some knowledge of neurologic recovery, but it's the recovery from a stroke is very different than what recovery from a brain injury looks like. And so they need to know how to help them with that. They're typically seen by an internist once a month, not a brain injury specialist, not a physiatrist. And the nursing care are typically nurses who don't have understanding of brain injury and how to deal with them. They're especially lacking in knowledge of those optimal management of the neurobehavioral sequelae, like I mentioned. They have higher rates of pressure sores, contractures, and medical complications like UTIs and pneumonia compared to sort of subacute brain injury specific programs. I've actually seen many patients who have, for whatever reason, had discharged from a SNF and had come back to me either in the acute hospital setting or in a subacute setting, and they're much more likely to develop these complications than if they had been in an appropriate facility. And they have a lower quality of life. Often they're left in bed continuously, given the concern for fall risk, that they don't want them to fall, so they don't let them get out of bed. I've seen that a lot. And at subacute brain injury programs, they're really focused on maximizing the quality of life and the functional independence. So patients get out of bed as often as they can tolerate, and at least daily, oftentimes 2 or 3 times a day. The patient will have a few hours out of bed, be allowed to move about the facility, with caregivers or independently, depending on what's safe for that person. Can be taken outside, can go out to the community for outings, when COVID allows. So there's a big change in quality of life from brain injury programs compared to a standard SNF. And there's really minimal opportunity for some of these outings and social engagement in a skilled nursing facility environment. So that's all I'm going to say about SNFs. But moving on, we have the residential transitional living program section. So these are really for they're sort of programs or facilities that really create a home-like environment. So it's a residential brain injury care home. Sometimes they're like a group home environment. There's lots of different names for these programs, but really the overall focus is that it's a home-like environment. It looks like a house, and they have their own room, and it feels like a bedroom. It doesn't feel like you're in a hospital room, in a hospital bed with nurses taking care of you and IV poles all around. It feels like you're in a home. And depending on the programs, they can have sort of graduated levels of supervision to match the emerging independence of the brain injury patient. So especially these sort of what I call the transitional living programs are sort of meant to take someone who's graduated from an acute rehab or a subacute rehab program, but can't quite be living independently. It can take them from a point where they have 24-hour supervision, but as they're showing more and more skill and ability, that supervision can back off, and they can sort of maybe be in a more remote apartment where they have to come and get their meds themselves. Therapy services are available within the facilities, or they can be transported to them regularly, and they have physician oversight. And the role of these is really a transition to independent living, and some of them may become a long-term care option, like a residential brain injury program, if there's not another home environment available. Then we have home and community-based therapy services. So with these, it's day programs, Rehab Without Walls, some neurorestorative programs do this, and this is really therapy programs that take care of the patient in the home, but different than a standard home health program. They also care for them out in the community. They take them out into the world, how to navigate crosswalks, how to go grocery shopping, how to deal with getting back to a work environment, all of those kinds of things. They not only have the brain injury trained therapists, but they have neuropsychology as part of their treatment team. And really the focus here is community reintegration. Now, just looking at the Careflow for sort of a mild TBI in the community setting, typically these are not coming through the hospital at all. They are initially evaluated by a primary care physician, maybe an emergency department or an urgent care. And I'll show you the symptom checklist that they should be using. They may or may not have had imaging. They typically are told to reduce their activities and given follow-up care. Here's the CDC symptom checklist. And really here, just to highlight that there's many things. The observed signs are things that the patient may not even be aware of themselves, but other people may have noticed and can report on. And then the symptoms are the ones that the patient experiences themselves. So physical symptoms such as headache or problems with balance, cognitive symptoms with difficulty concentrating, and emotional symptoms. And now we can go ahead with the third and final poll question. I can't see it. Do we have the poll question up?
I have it up, and the votes are coming in. So just a final reminder to please answer the poll question if you would like to earn credit. Thanks.
Thanks, guys.
We're at about 87%, so we'll just give it about 10 more seconds.
Great. Thank you, guys. Again, it's not meant to challenge you too much, just to document your participation.
Alrighty, looks like just about everyone has gotten their vote in, so we will move on. Thank you.
Great, thank you. And so moving on here, I'm not going to go through this in detail, but just to give you an example of this is what a concussion exam should look like. So there should be really a detailed cognitive assessment, looking at the different areas of cognition to really make sure that they've been properly evaluated. And then typically, they're going to need follow-up care, either with a primary care, with a primary treating physician for the work-related injury, or maybe referral to specialists for a brain injury care. The recovery period, really historically, it was reported that 90% of patient symptoms resolved in 7 to 10 days. But more and more research is really showing that it's actually more common to have symptoms longer than this. And if they're really still symptomatic at 2 to 4 weeks, it would be recommended that a patient with a mild TBI be referred to a brain injury specialist who really knows how to identify their symptoms and really provide appropriate treatments for them. Here's post-concussive syndrome, just really the idea that the symptoms can go on longer term, 2 months to 3 months, or really long term, last a year or longer. Some patients who really present with a mild TBI actually go on to have permanent symptoms and long-term cognitive disabilities because of this. But it's really the same symptoms you would see for the mild TBI. It's just that they continue. So then just to speak a little bit about what other additional care looks like in the outpatient setting, and this would be for really all the full spectrum of brain injury, from moderate and severe and mild, once they're sort of in an outpatient community or home type setting. This is some of what they'll need in that setting. And there's really the medical specialties who will be trained to diagnose and treat TBI. So physiatrists like myself, a physical medicine and rehabilitation specialist, neurologist, neurosurgeon, psychiatrists, psychologists, neuropsychologists, and then the therapists. They don't technically diagnose because they're not doctors, but they do really detailed evaluations and identifying symptoms and deficits. So they're very useful in that regard. But you do want to make sure that any treating clinician has brain injury expertise, because not all physiatrists or neurologists really specialize in brain injury. Some of them are primarily musculoskeletal, or maybe it's an epilepsy or headache trained neurologist, and it's just not really their area of expertise. Sometimes there's other specialist involvement. So there's neurology subspecialists like the headache doctor or the epileptologist who they need to see for that particular symptom they're having related to their brain injury. And neuro-ophthalmology, vision disturbances are very common in brain injury. It's not that the eye has been damaged or the optic nerve, but the way the brain processes visual information can be impaired. And they need to see a neuro-ophthalmologist and or neuro-optometrist to evaluate that. ENT is very common for vertigo or balance impairment or hearing loss. And then just lastly, a brief bit in terms of really looking at TBI as a lifetime of care, meeting cognitive deficits and supervision needs. Really, there's a complexity of cognitive deficits with it that all the things we talked about earlier on really create a situation where patients with brain injury often require 24-hour supervision or some level of supervision, and it can be for a period of time during their recovery, and it can be for the rest of their life. With mild TBI, they can actually have degenerative changes as they age, so they can actually get to a point where they need, they're more likely to get dementia, for example, twice as likely as someone who didn't have a mild TBI. And they might need full-time care later in their life because of that injury sustained earlier on. They can be walking wounded where they look good. They're moving around. They're like, nobody sees physical deficits. They can talk. They can carry on a conversation. People don't understand how impaired they are. But they can be really have that poor safety awareness, poor executive function, can't get themselves through the day and take care of their basic needs, even though they look so good. And with more severe TBIs, the combination of physical and cognitive impairments often leads to a need for lifelong supervision and physical assistance to help them with all of their care needs every day. A few little things on here on poor prognostic indicators. So things some clues we have earlier on that you're going to have a really poor outcome would be being greater than 12 weeks to emerge from the minimally conscious state. So if it's more than 3 months and you're still in that minimally conscious state, that's not a good sign. Greater than 16 weeks to emerge from that post-traumatic amnesia or a confusional state. Recovery is better for traumatic brain injury than non-traumatic. So non-traumatic would be, a good example would be like hypoxia or anoxic, not getting enough oxygen to your brain, either from like a near drowning or a heart attack where your blood's not pumping, not perfusing your brain. Those kinds of things tend to do worse than traumatic brain injuries. And we find that even though if you keep following these patients, even between 2 years and 5 years post-injury, they can make progress. Patients who are still in the vegetative state at 2 years, there's a chance they could still come out of it by 5 years after injury. The longer you look and watch these patients, the more you actually see recovery continues to happen. And now these are better prognostic factors. So signs that your outcome may be better. So time lag from injury to rehab, how quickly they're getting into and appropriate for acute rehab. The change in their coma recovery scores over the first 3 weeks on rehab. If they're changing quickly, that's a good sign that they're going to have a better overall recovery. The time to clear out of that post-traumatic amnesia. So that's just that knowing where you are and why you're there and what's happened to you. If it's taken more than 3 months to get out of PTA, then 0% had a good outcome. If it's less than 2 months, then there was a low chance of severe disability. So that's that's really a useful marker. But as you can see, it takes time, 2 to 3 months, to really know that. It's not nothing you're going to really know in the first 3 days. And higher FIM scores at the end of acute rehab. So the better they're doing at the end of acute rehab, the better they're going to do overall. Kind of makes sense, right? So that's the end of the presentation. We have 5 more minutes left, so I'm very open to any and all questions. If you guys have any to submit, feel free to write them in the chat or the question section, whatever you can see.
Okay, we've had a couple questions come in so far, so I'll just start with those. The first being, how do they know if a TBI patient is tolerating therapy if they're unconscious?
Oh yeah, that's a great question. So typically the tolerance has to do with their ability to sit out of bed and at least be alert for the session. So if they're in a vegetative state patient is doing an acute rehab or even subacute rehab, they have to be able to be up out of bed in a wheelchair and engage with the therapist, even if they're that just means they're alert, their eyes are open, they're sitting there, they're doing something with them. So they have to be able to at least do that. A lot of times tolerance issues come up with fatigue for patients who the consciousness isn't the problem, but it's more the fatigue and pain. So it's really a big barrier if they have fractures and they're hurting too much to be up in a sitting position. They're up for like 20, 30 minutes and they're like, I have to go back to bed. I have to lay down. I can't be out of bed any longer. That's a big problem. And then sometimes it's just fatigue that they can only be engaged for that 20 to 30 minutes and then they conk out and they're sleeping for the rest of the therapy session. So that's a person who would be more appropriate at a subacute rehab level until they could be alert and maintain that alertness for a full, it's 3 hours, but it's usually twice a day. So it's a good 1.5 to 2 hours twice a day. So at least if they can be out of bed for 1 hour to 2 hours, then they're probably ready.
Okay, great. Thank you. The next question is, in cases of concussion with chronic symptoms for 3+ years, how would you rule in or out the existence of other potential causes of the symptoms or the lack of recovery, such as depression, sleep deprivation, age-related brain changes, personality disorder, or other neurological conditions, etc., when the patient shows no improvement with long-term multidisciplinary care?
Yeah, I think you're right that those are often comorbidities that can affect the way the person's presenting. So we know that severe depression can affect your cognitive functioning. And so really the way to do that is to just make sure they have the appropriate treating physicians on board who are evaluating all of those things and treating all of those things. If they're depressed, then they're getting appropriate treatment for depression. They're evaluating them neurologically to make sure do they have signs of Alzheimer's dementia in addition to the brain injury? Are there other things going on that can affect it? But it is very possible for patients with mild TBIs to have sort of they often will improve. Their symptoms don't usually stay awful the whole time, but they get better, but then they can plateau where they can stay with some symptoms for many years, if not lifelong. So it can happen and it can be brain injury related, but you really just have to have other treating physicians make sure they're evaluating for all these other things. And if they're there, treat them. Sometimes it's just too complex to really tease it out and say with certainty, which one it is related to. Can be sort of all the combination of things weighing in can lead to the symptoms that you see.
Okay, great. The next question is, what are your thoughts on the efficacy of the right eye test to confirm TBI?
The right eye test. I'm not sure I know which one that is. I'm so sorry. I don't know that name. The test by that name.
Okay, we can always contact that individual via email and discuss that. Okay, great. Next is, if a person is not conscious, do they still perform range of motion daily?
Yeah. So a lot of times for patients who are sort of in that vegetative state or maybe persistent vegetative state where they're in it for a long period of time, it's definitely important to do a daily range of motion program. And a lot of times it's splints or braces to kind of help keep them in good positioning. It doesn't always need to be a skilled therapist doing it. Initially, it will need to be because they need to figure out, okay, what's the best way to range this patient and what's the best splinting or bracing program for them to be in, which kinds of devices and how many hours a day. And that eventually that program can be transitioned to sort of an aide or a family member if they're in a home setting. But absolutely, the range of motion needs to be done on a daily basis. And typically a couple times a day, ideally, because the benefits of stretching in terms of relaxing muscles is if you have like tight muscles from brain injury, like spasticity, the benefit lasts only hours. So you really have to do it ideally once or twice a day.
Okay, great. Next is, can you describe the diminished, the diminished life expectancy aspects of TBI patients? What are some of the conditions that can develop that lead to a diminished life expectancy?
Yeah, the biggest factor has to do with their swallow function. So if they've been able to regain the ability to eat on their own, to feed themselves, and to eat solid food by mouth, that is the best predictor of having a more normal life expectancy. If they're requiring tube feedings, then that's one of the biggest effects on their life expectancy. So if they're not able to eat by mouth, they have to be fed by tubes, and that's definitely going to shorten their life expectancy. Other things can come into play, such as other complications like hydrocephalus, if they develop that and need a shunt placed, seizures, infections like pneumonias or pressure sores. All of those things can come into play. And that's really why you want to have them in a good program that can identify those things, prevent them, the ones that are preventable, and treat them early on, such as the post-traumatic hydrocephalus. Identify it and get it treated early on rather than waiting.
Okay, great. Another question that came in is, assuming the family is agreeable to a loved one going outside of their geographic area for the best care initially, how or at what point should the family be a more active part of the process and training for a transition to the last place of residence for the patient? So assuming that the individual has a supportive family or a loved one as part of the process.
Yeah, that's a great question. It really depends on what they're able to do. I think it's always better for the family members who's going to be ultimately be the caregiver in a home setting. If they can participate early on, it's all the better, because they'll be able to see through each stage what the recovery looks like, learn if they can care for them in the dependent stage, but as they get better and better, it's only going to be easier. But if they're learning with participating, watching, doing hands-on, helping do the transfers, out of bed with a Hoyer lift, learning how to do that from, the first weeks of rehab, they're going to feel confident. They're going to feel ready later on. That being said, not every family can do that. So sometimes it's a matter of they have to be home working for a while, taking care of family at home, taking care of children or parents at home who need their help too. So typically, on the more severe side where they need really hands-on 24/7 care, I recommend that at least the last 2 weeks of the rehab stay, they come back and participate if they can't be there throughout the whole process. It usually takes about 2 weeks of, daily hands-on training to be able to, if for someone who's really in a high care burden, to really train them where they feel confident and safe and successful to make that transition home.
Okay, great. Looks like our last question is, how long can a person survive solely on a G-tube?
That it really can be decades. I mean, it doesn't matter that if they're getting the nutrition and the hydration that they need with it. So it really can be decades, depending on what their age at the time of injury. But definitely.
Okay, great. And then just a couple comments I will share anonymously. Someone mentioned that this information was very helpful. Their 82-year-old father suffered a TBI in 2019 from a fall. He's come a long way from initially being in a vegetative state. He's now able to somewhat care for himself and is still a resident at a rehab facility.
Wow. Yeah. Yeah. It always amazes me to see what patients can do and what families can do. And it's really amazing work to see. Yeah.
And then there was another comment, kind of a question, said SNF seems to be very emotional for you.
Which part?
It says SNF or SNT.
SNF. Oh, SNF.
Oh, sniff,
Yes.
sniff, sorry.
Skilled nursing facilities. Yes, I have seen lots of bad things happen to my patients who've had brain injuries and spinal cord injuries who've gone to SNFs. And so for patients who have these particular diagnoses and who can't care for themselves either because of cognitive deficits or because of their weakness, because of their spinal cord injury, SNFs are very, they're great and they serve a very good purpose, but they're not ideal for patients who have these particular types of neurologic deficits. And so if you can find a program that's specific for those diagnoses, they're going to have much better quality of care. And I do feel very, very passionately about that for sure.
Okay, awesome. And that looks like that's just about all the questions and comments. So we'd like to thank you all for attending today. In about an hour, you'll receive an email from us just with a short survey asking if there's any topics that you would like to hear about in the future. If you could just send those our way, that would be great. And then if you are eligible for the credits, you will receive an email from CEU Institutes within the next couple days. Thank you again, and we hope you have a great afternoon. And thank you, Dr. Spalding.
Thank you. Thank you all for spending time with us. We appreciate it. Take care.